Treatment-resistant depression is defined as the failure of two properly conducted antidepressant trials. That is the textbook definition. It is also the kind of definition that on first encounter looks deceptively simple and on the second dissolves into a small cloud of further questions. Two trials, failed, properly conducted. Each of these three terms is doing more work than it appears to be doing, and it is worth examining each of them carefully before we proceed any further. Because if you do not understand what these words really mean, in the strict operational sense, then the entire concept of treatment resistance becomes rather vague. It becomes a label that gets applied to anyone whose mood has not lifted on the first or second pill they were prescribed, regardless of whether those pills were prescribed competently. That is not what treatment resistant is. That is what poor treatment looks like. So let us begin with the word failed, because it's the most slippery of the three. When we say a treatment has failed, what exactly do we mean? Is it the failure of the symptoms to disappear entirely? Is it the failure of the symptoms to improve at all? Is it the failure of the patient to feel categorically better in some self-reported way? None of these definitions, it turns out, is what we actually use. The clinical definition relies on two carefully calibrated terms that are routinely confused, even by people who ought to know better, and that confusion has consequences for real patients. The two terms are response and remission. They are not synonyms. They are not interchangeable. They are describing two different things, and the difference between them is the difference between a partial victory and a complete one. Response, or treatment response, is defined as a 50% or greater reduction in the patient's initial symptom burden as measured by a standardized rating scale. The Hamilton, the Madras, the PHQ-9, pick your instrument. The patient came in with, say, a Hamilton score of 28, which is severe. After treatment, the score is 12. That is a 57% reduction. The patient has responded. Note what this does and does not mean. The patient still has symptoms. The patient is still, by any reasonable clinical standard, depressed, but the patient is meaningfully less depressed than they were. The treatment is doing something, but it may not be enough. Remission, by contrast, is the goal. Remission means that no more than 2 mild residual symptoms remain. The patient is not just better, the patient is essentially well. They are functioning, they are sleeping, they are interested in things again. There may be some lingering tiredness, some occasional flatness, but the illness is, for practical purposes, no longer present. The distinction matters because patients who respond but do not remit have a substantially higher risk of relapse than patients who achieve full remission. Residual symptoms are not just cosmetic flaws on an otherwise successful treatment. They are predictors of return. They are warning lights on a dashboard that has not been fully repaired. So, when we speak of treatment failure, what we mean strictly is the failure to achieve either response or remission. The patient who responds but does not remit on the first medication has not, strictly speaking, failed. They have partially succeeded. And, as we shall see, this distinction has significant consequences for what we do next. Now to the second term, properly conducted. This is where the wheels come off in clinical practice more often than anyone wants to admit. A properly conducted antidepressant trial is one in which the medication has been raised to either the maximum recommended adult dose or the maximum dose that the patient can tolerate, whichever is reached first, and held there for at least 8 weeks. 8 weeks, not 3, not 5, 8, at full dose. I emphasize this because the most common failure mode in psychiatric practice, and I see this constantly in patients arriving for second or third opinions, is the underdosed, prematurely abandoned trials. A patient was started on 20 milligrams of fluoxetine. 6 weeks later, with little improvement, the medication was stopped and another one was started. That is not a failed trial. That is not even a trial. That is a starting dose held for an inadequate period and abandoned before the medication had a chance to do what it was designed to do. Or here is another scenario, even more common. A patient was started on medication. 2 weeks in, the patient reported nausea or insomnia or a headache or some sexual side effects. The medication was stopped. Did the medication fail? It did not. It was not given the opportunity to fail. It was withdrawn before the question of efficacy could be even addressed. Medication that is discontinued because of side effects has not failed in the technical sense. It has simply been disqualified from the contest, often because of a starting dose that was too high or a titration schedule that was too aggressive, or, and this is by far the most underappreciated cause, the absence of any titration schedule at all. What does a proper titration look like? Here is the unassailable version. Begin at half of the lowest commercial strength of the medication, half of the lowest. So if the medication comes in tablets of 10 milligrams, as its lowest available dose, begin at 5 milligrams. Hold for a week, increase by 20 to 25% of the dose every week thereafter, until you reach either the maximum tolerated dose or the maximum recommended adult dose. Then and only then do you start counting your 8 weeks. Run the arithmetic. Titration to the therapeutic dose, 4 to 6 weeks. 8 weeks at therapeutic dose, another 8. Total time to know whether the medication has worked, roughly 3 months, 12 weeks. From the day you began the trial to the day you can pronounce on its outcome, you are looking at the better part of a season. This is, I grant, not what patients want to hear. They want relief, and they want it now. But the alternative, the rushed titration, the inadequate dose, the truncated trial, is the alternative that produces a long string of medications that have apparently not worked, when in fact none of them was ever properly tested. Now, of course, there are situations in which you cannot afford to take 3 months. Severe acute presentations, the patient who is not eating, not sleeping, not safe. These patients require a more aggressive approach. You may need to titrate more rapidly in larger steps, accepting a higher risk of side effects in exchange for a chance of earlier benefit. The titration schedule should also be adjusted at the extreme ages. The very young and the very old require slower starts, lower initial dosages, and more cautious increments. Their physiology is less forgiving, their pharmacokinetics less predictable. The titration schedule should also be slower in patients who have never taken psychiatric medication before, and slower still in patients who arrive with significant apprehension about the very category of medication you are about to prescribe. This is not pandering to anxiety. It is a sound pharmacological practice. The nocebo effect, the production of side effects by expectation rather than pharmacology, is real, well documented, and especially common in patients who have been told by friends, by relatives, by the internet, that psychiatric medications are dangerous, mind-altering, soul-destroying. Such patients will produce side effects from a sugar pill if you give it to them at the wrong dose with the wrong tone of the voice. A slow, gentle, almost diplomatic titration gives the patient time to adjust, time to observe that the building is not in fact on fire, and the time to develop a working relationship with the medication. Suppose then that you have done all of this properly. 2 medications, 2 proper trials, full dosages, 8 weeks each. The patient has neither responded nor remitted. By the strict definition, the patient is now treatment resistant. What now? There is a strategic fork in the road, and which path you take depends on a single question. Did the previous medication produce any benefit at all? If the previous antidepressant produced no benefits whatsoever, if there is no glimmer of improvement, no partial response, nothing, then the rational move is to replace it. There is no point augmenting a medication that is not contributing anything to the patient's recovery. You take it away and try something else. If, however, there was some benefit, some response, even if it fell short of remission, then the preferred strategy is not to replace the medication but to add to it, to augment. The logic here is straightforward. The medication is doing something useful. Removing it discards what has been gained. Adding to it builds on what is already there. Now you might think the obvious way to augment antidepressant is to add another antidepressant, and this is indeed sometimes done, but it is not the first-line strategy, and there is a good reason for that. If you do combine two antidepressants, you must, and this is a rule with no exceptions, ensure that the two medications do not have the same mechanism of action. You cannot combine an SSRI with another SSRI. You cannot combine an SNRI with another SNRI. Combining two medications that act on the same receptors and transporter does not give you twice the benefit. It gives you twice the risk of side effects and very little additional therapeutic gain. The point of combination is complementarity, not redundancy. If you are going to combine antidepressants, you must choose two that work on different pharmacological systems. But, as I said, a combination of two antidepressants is generally considered inferior to alternative strategy, which is augmentation with non-antidepressant agent. The classical augmenting agents, and here I mean classical in the historical sense, not in the sense of being the only options, are four in number. Lithium synthroid, which is to say levothyroxine, buspirone, and L-methylfolate, marketed as Deplin. Of these four, lithium has the longest and most established track record. The evidence base for lithium augmentation of antidepressants stretches back decades, and the effect, when it occurs, can be substantial. Lithium remains the augmenting agent against which all others are measured. Levothyroxine or synthroid has shown in some studies a slight superiority over lithium and the others, particularly in patients who appear euthyroid by standard testing, but who may have subclinical thyroid involvement in their depression. The effect is modest by real, and the side effect burden is, at properly chosen doses, low. Buspirone occupies the middle ground, less effective than lithium or thyroid hormone, but more effective than methylfolate, with a side effect profile that is generally well tolerated. Buspirone has a particular niche. It is especially useful in patients whose depression is accompanied by significant anxiety, whether or not that anxiety meets formal criteria for an anxiety disorder. If your patient is depressed and visibly anxious, agitated, ruminative, restless, buspirone is a sensible choice. L-methylfolate is the gentlest of the four, both in terms of efficacy and in terms of side effects. It is, as a rough approximation, the weakest augmenting agent in routine clinical use, but it is also the one least likely to cause anyone any trouble. In a patient who is fragile, who has tolerated previous medication poorly, who is reluctant to add another pharmacological active agent, methylfolate is a reasonable and low-risk first augmentation step. So far, so good, but these four are not the only augmenting agents available. In the last 20 years, a second class of medications has come to dominate the augmenting landscape, and that class is the atypical antipsychotics. Several of these are now FDA-approved, specifically as an adjunctive treatment for major depressive disorder in patients who have not responded adequately to antidepressants monotherapy. As of late 2025, the list runs as follows. Aripiprazole, marketed as Abilify, was the first one to be approved in 2007. It remains the most extensively studied of the group, and in many practices the default choice when atypical augmentation is considered. Quetiapine, marketed as Seroquel, was approved for this indication in 2009. It has the practical advantage of being usefully sedating in patients whose depression is accompanied by insomnia, though the same property is a liability in patients who already feel cognitively dulled. The combination of olanzapine and fluoxetine, marketed as Symbyax, was approved in the same year specifically for treatment-resistant depression. This is the only combination product on the list, the antidepressant and the antipsychotic package together, and it carries the metabolic burden one would expect from olanzapine. Brexiprazole, marketed as Rexulti, was approved in 2015, a close pharmacological cousin of aripiprazole with a slightly different receptor profile and, in many patients, a slightly better tolerability profile. Cariprazine, marketed as Vraylar, was approved in 2022, distinguished by its dopamine D3 preferring partial agonism. It has earned a place in the augmentation toolkit, particularly in patients who have not tolerated aripiprazole or brexiprazole. And the most recent addition, approved in November 2025, only months ago, is lumateperone, marketed as Caplyta. The clinical trials supporting its approval showed efficacy comparable to the older agents, but with a strikingly favorable side effect profile. minimal metabolic disturbance, minimal weight gain, minimal extrapyramidal symptoms. If the early enthusiasm holds up in real-world practice, lumateperone may displace several of the older agents as the first-choice antipsychotic augmenter. 6 atypical antipsychotics, in summary, FDA-approved for adjunctive treatment of major depressive disorder: aripiprazole, quetiapine, olanzapine fluoxetine combination, brexpiprazole, cariprazine, lumateperone. 6. That is your formal list. Now I want to make a point that is, in my experience, almost always overlooked, even by clinicians who pride themselves on thinking carefully about depression. Psychotherapy is also an augmenting agent. I do not mean that as a turn of phrase, I mean it as a strict logical claim. The category augmenting agent denotes any treatment added to an existing antidepressant to improve outcomes. Lithium is an augmenting agent. Aripiprazole is an augmenting agent. Cognitive behavioral therapy added to an existing pharmacological regimen is also an augmenting agent. The fact that it is not pharmaceutical not move it out of that category. The fact that it cannot be prescribed in milligrams does not exempt it from the same logical and evidentiary standards. And as it happens, the evidence based for psychotherapy augmentation of antidepressants is substantial. Effect sizes comparable in many studies to lithium augmentation. Patients who receive both pharmacotherapy and psychotherapy do better on average than patients who receive either of them alone. This is one of the more robust findings in the depression treatment literature and is routinely ignored in clinical practice because it does not come in a tablet form. So when you are sitting opposite a patient who has failed 2 antidepressants and you are reaching for the third pill, pause for a moment and ask yourself whether the addition of a structured psychotherapy might be the more elegant move. Beyond augmentation, of course, there are the non-pharmacological interventions. Electroconvulsive therapy, ECT, remains, despite its public image, one of the most effective treatments in all psychiatry, with response rates that exceed every other modality. It is dramatically underused, partly because the public stigma, partly because of access difficulties, partly because of the time and resource burden it imposes on patient and family. But for severe, persistent treatment-resistant depression, particularly with psychotic or catatonic features, it remains the gold standard. Transcranial magnetic stimulation, TMS, is the gentler cousin, less effective than ECT in severe cases, but with no anesthesia, no memory effects, no significant downtime. For the treatment-resistant patient who balks at ECT, TMS is a serious option. The evidence base has grown considerably over the past decade, and several variants, accelerated protocols, theta burst stimulation, have expanded what is possible. And then there is esketamine, the nasal spray formulation of the dissociative anesthetic ketamine. Esketamine can be used as monotherapy in treatment-resistant depression, and it can be added to an existing antidepressant regimen. The mechanism is fundamentally different from any of the conventional antidepressants. It's glutamatergic rather than monoaminergic. And the time course is fundamentally different as well. Patients can show meaningful improvement within hours or days rather than weeks. The drawback is the requirement for in-clinic administration and observation, but for patients who have failed multiple conventional approaches, esketamine has opened a door that 20 years ago simply did not exist. I want to make one final observation before turning to the optimistic part of this discussion, because the observation is, I think, not sufficiently appreciated. Treatment-resistant depression is not defined by intensity. There is, in fact, very little correlation between the severity of depressive illness and the responsiveness to treatment. Major depression can present with extraordinarily intense and disruptive symptoms, suicidal ideation, profound anhedonia, complete inability to function, and respond beautifully to the first medication tried. The opposite is also true. A depression of relatively modest intensity, what one might be tempted to call mild or moderate, can prove stubbornly, exasperatingly resistant to one treatment after another. This is counterintuitive, but it follows logically from the nature of treatment resistant. Resistant is not a measure of how loudly the disease is shouting. It is a measure of how well the disease is hiding from the medications we have. The two are different properties, and they vary independently. This brings me finally to the optimistic point I promised, and which I want to make carefully, because I do not believe in cheap optimism in psychiatry. Cheap optimism is corrosive. Patients can detect it, and they correctly read it as a substitute for genuine engagement. But there is a kind of mathematical optimism that is, I think, entirely warranted. Consider the combinatorics. There are roughly 26 antidepressants currently on the market. There are 6 atypical antipsychotics with FDA approval for adjunctive use. There are additional 12 to 15 medications with reasonable evidence supporting augmentation, even if not formally indicated. The arithmetic gives you, by some estimates, in excess of 1,300 distinct treatment combinations before you factor in the non-pharmacological options, the psychotherapies, the stimulation modalities, esketamine. 1,300. Now, in fairness, the practical reality of managed care will reduce that number considerably. Insurance, formularies, prior authorizations, requirements, step therapy protocols, the eternal bureaucratic friction that has been allowed to colonize the doctor-patient relationship. All of these will narrow your effective options to perhaps a few hundred. That is still, I would submit, a great many options. It is enough. The pessimism that creeps into the third or fourth or fifth medication trial, the patient's pessimism, but also the clinician's pessimism, which is almost always more dangerous because the patient detects it and internalizes it, that pessimism is mathematically unjustified. There is no statistical basis for declaring a patient untreatable after 3 or 4 failed trials, given the size of the option space that remains. There is every reason for measured persistence, for systematic exploration of the remaining options, for the calm and methodical application of the principles I have outlined. A failed trial, properly understood, is not a closed door. It is information. It tells you something about which mechanisms are not, in this particular patient, doing the work. It narrows the search, and the search continues, because the alternative, to declare a patient beyond help on the basis of 3 or 4 data points out of more than 1,000 possible interventions, is not science. It is fatigue dressed up as a conclusion. Treatment-resistant depression is, in the end, less a category of disease than a category of treatment history. It is a label that describes where the patient and the clinician have been, not where they are going. And where they are going, in the great majority of cases, is somewhere considerably better than where they are now, provided, of course, that the trials are conducted properly, the augmenting strategies are deployed thoughtfully, and the clinician retains the patients to count to 8 before reaching for the prescription pad again. If after reading all this you still feel pessimistic, I would gently suggest that you have miscounted the doors. There are rather a lot of them, and most of them have not yet been opened.